a little differently compared to Western medicine. And we actually use what we call a network of networks approach. So back when I was an obstetrician gynecologist, 7 years ago was the last delivery I conducted. So we used to look at only our own specialty. So as an OBGY, I would only look at the uterus, tubes, ovaries. Anything outside of that was not my territory. But in functional medicine, we look at the whole patient because we know that everything is connected to everything else. Now, few caveats. If you are here for one of the first events, this is the first thyroid hormone event that you've come to from a functional medicine perspective, not, of course, the regular Western medicine, then some of the information may seem a little overwhelming. And I do apologize for that because, as Dr. Sarah will agree with me, for some of the first webinars and first events and conferences we went to, we felt, oh, good grief, where have we landed? There's so much we don't know. But bear with me, it's once you start the process, some of you are at different stages in the practice. Once you start it and you continue learning, you'll realize that it makes so much more sense. And one more thing I wanted to say is you will get a copy of the slides. And I have added the references on the last slide because some of the concepts may seem like, it's not possible for me to explain in details in this time, in this less than 1 hour. So I would suggest you go to those actual references and go through them in details. Most of them are open access, so you shouldn't have a problem getting those references at all. So thyroid hormones, now I am not going to talk about hyperthyroidism. I'm only going to talk about hypothyroidism. And the commonest form of hypothyroidism is Hashimoto's. So when we look at Hashimoto's from a functional medicine perspective, how are we going to diagnose Hashimoto's? I'll not go into great details because most of the basic stuff you know. The only thing I want to mention is, again, it's different things in different parts of the world, but I think in most of Asia, we look at TSH, T3, T4. Some people look at free T3, free T4. Some people look at total T3, total T4. However, the additional tests that we do, which I wasn't doing when I was an OBGY, is testing for the thyroid antibodies. So a very basic thyroid function test for us is TSH, free T3, free T4, the anti-TPO antibodies and the anti-thyroglobulin antibodies. But in traditional medicine, I think most of you are probably used to doing a TSH, free T3, free T4, not always a thyroid antibodies. And the reason being, before I got into functional medicine, we didn't know how we could reduce somebody's thyroid antibodies. So as I remember having a conversation with an endocrinologist many years ago, he said, what is the point in finding out about antibodies when we can't do anything about it? At that point, I wasn't educated in functional medicine. Today, I can say that there are things we can do to reduce antibody levels. So what are the important questions I want to answer today? What is an optimal TSH level? Should you treat subclinical hypothyroidism? I will define subclinical hypothyroidism. Should you treat with T4 monotherapy? So T4 monotherapy is the Synthroid, the Levothyroid, the traditional one that all of us are used to. Or should you consider a combination treatment with T4 and T3? And when should you consider a trial of combination therapy? What about desiccated thyroid preparations? And a very interesting question, which actually, Sarah, this thyroid set point is based on the work of an endocrinologist from Singapore. So, and I am hoping to have time at the end for questions and answers. And in case I'm not able to get to all your questions, please send them to Dr. Sarah, and I will try to the best of my ability to respond to them by email. Now, I don't want to spend a lot of time in thyroid hormone synthesis because you can get all this information already. But what I do want to stress upon is what is relevant for us in terms of, looking at the treatment. So one is, sorry, Sarah, I'm just asking, are you recording this?
Yes.
Okay, I can't see the recording. So anyway, sorry about that interruption. So
That's all right.
T3 is the biologically active form of thyroid hormone, and T4 is the pro-hormone to T3. So basically, T4 has to be converted to T3 because T3 is the active form of the thyroid hormone. Now there is T1, T2, but we don't exactly know about what those really do in the body. So the thyroid gland produces 100% of the circulating T4, but only 20% of the circulating T3. This means that the T4 to T3 conversion has to happen in the peripheral tissues like the liver, the kidneys, and all those. So this is important because if someone has, diseases in the liver or the kidneys, then the T3 conversion may not happen. There are other factors as well important for the conversion of T4 to T3, and that is the reason in some countries, even in Canada, some provinces, some doctors only look at a TSH to find out if thyroid is working well or not. And we can't always say that. I'll come to that when I talk about the subclinical hypothyroidism. So this is where the thyroid hormone synthesis part of it is important. Now, the other area which is very important are the deiodinase enzymes. So, very briefly, this is what happens. T4 is converted to T3 and reverse T3. Now, in all those conversion steps, there are these three types of deiodinase enzymes. As you know, anything that ends in SE is an enzyme. Deiodinase means it removes the iodine molecule from that. So T4 gets converted to T3 and reverse T3. Now, reverse T3 is the inactive form of the hormone. And then both reverse T3 and T3 get converted to T2. So basically, and if you have been reading up, sometimes you'll find in a lot of internet, forums and blogs, people will talk about how your T3 and reverse T3 need to be in a certain ratio. Well, the fact is, to cut short on a long story, we still don't know enough about reverse T3 to know whether that is so very valuable. Because the other thing is, when you start trying to manage ratios of this into that and that into this, what ends up happening is very often we become what we call micromanagers of thyroid. So TSH has to be one specific number and T3 has to be in this ratio with reverse T3, and you're like continuously changing the prescriptions and trying this and trying that and adding in like 2000 supplements. That is not what we talk about. What we recommend is, don't look just at the lab numbers. Look at what the patient is telling you. What about the symptoms? What is changing? Has anything happened in her life recently? Has she gone through a stressful experience? And I'm saying she mostly because most of our patients are women, because Hashimoto's is more common in women than in men. However, I do have men patients who have Hashimoto. So it's not unknown in them, but as in all autoimmune conditions, women have a higher incidence than men. So again, the selenoiodinase enzymes are the important ones. As you can see, D1, D2, D3. And D3 is important because that is the inactivating enzyme. And the thyroid, liver, kidneys, these are the target tissues. So the other important thing is look at D2. So type 2 deiodinase enzyme is very important in the brain. Now, why am I stressing on that? And you can check Dr. Antonio Bianco's website. His lab has done a lot of work on the deiodinase enzymes. So, one of the things that happens is a few studies have found that if people have a genetic variation in the D2 enzyme, deiodinase enzyme, then just giving them T4 only may not always help, because that it is possible that that conversion of T4 to T3 in the brain is not happening as well. But while I'm saying that some studies have shown genetic variation in the enzymes can have an impact, others have not completely supported it. So bottom line, you cannot do a deiodinase enzyme testing and figure out if you or your patient is going to be benefited by using a T4 and T3 combination or only T4. It is still test, treat, and repeat. And it's always listen to what the patient is saying, what is going on, what are the symptom complexes, not just based on a certain lab numbers. And anyway, we cannot test for the deadenase enzymes in a clinical setting. Research setting, yes. So what are the different factors affecting thyroid function? I'm just going to keep that slide on for a minute. And you can see that looking at thyroid and just checking only TSH free, T3 free, T4 will not be enough. There are so many other factors which have a huge impact. Age. Now, younger people, it is a different modality of treatment versus someone who's older than 65 years. An older person, we may be a little more tolerant about a little higher TSH levels than a younger person. Then there are a whole bunch of drugs that your patient may be taking. And I do have a list here today. But like all of you, what I do usually is, because this knowledge keeps getting updated all the time. And it's very difficult to keep up with all the knowledge. So if a patient is on a particular medication, what I do is I just check whether that medication has any impact on thyroid functions. However, few are major ones, which I will point out when I come to that slide. Nutrients, illness. So acute illness, there is an entity called euthyroid sick euthyroid syndrome or euthyroid sick syndrome. Again, I won't have time to go into that, but the point is, when you're looking at a patient's labs, you have to keep the entire context in mind. You cannot just look at the labs and say, okay, you need to be on thyroid medications. Because another thing you need to remember is, usually thyroid supplementation is for life. This is one common question I get a lot from my patients. Doctor, will I be able to stop my medicines? So, and I'm sure you all get the same question as well. So number one is, it depends on how much of your thyroid tissue is still there. If it has been destroyed by a radioiodine treatment, then obviously you will need lifelong. However, if it is Hashimoto's, an autoimmune process, there is no single way to find out that how much of thyroid reserve is still there. So some patients of mine have been able to get rid of their medications completely. Many of them have been able to reduce their dosage, but I never guarantee that you will be able to get rid of all your medications and you're just going to be fine. No, that is very difficult to say, because each person is different. And again, it depends on what their lifestyle is, how much of it they are able to, maintain, what are the things they are able to do. So what is an optimal TSH level? Like, all of you must have in your country, you have a definite lab range. Usually for most, it is between 0.4 to maximum 5 milli international units per ml. Depends, some countries, some places have 4, some people have 5 as an upper limit of normal for TSH. Sarah, what is the commonest level normally given in your labs?
That there's a few different labs and it's different range too, but I think that between 0 to 4 something.
Yeah. So it is a definite number. Now, the fact is, this is what happens, there are many factors which can produce an aberrant TSH level. So this is a very good paper to read. Dr. Salman Razvi from the UK has done a lot of work on thyroid, and he has done a lot of work on thyroid and the heart. So you can see that there are some factors which influence the TSH secretion, some interfere with the TSH test, and some interfere with the absorption of levothyroxine. And in that list, you can see, so one of the commonest interferences with the TSH test, and in labs in Alberta, where I am, what the lab gives a little a note on the test, this thing where biotin can interfere with your TSH test levels. So usually people are recommended to stop their biotin before they go for the test. Then you can see the ones in blue are all those, renal failure, and macro TSH is something, again, a type of a TSH molecule which interferes in the testing. So if that is the case, then the problem is not with the patient's thyroid function, it is because of the interference with the test. Then, of course, calcium, iron, iodide supplements, dietary soy. These will interfere with the absorption of levothyroxine. And as always in functional medicine, we look at the gut first. So someone who doesn't have a healthy gut, and I'll come to, briefly to how we are going to start off with treating a patient. We always start with the gut. So unless the gut is healthy, it is very difficult for us to balance everything else. Then comes, so metformin. How common is that? Metformin and PPIs, so proton pump inhibitors like omeprazole, lansoprazole. I don't know about, your countries. Many people in India use proton pump inhibitors like they are candy. They'll just have them. Oh, I'm feeling a little gassy. I'm feeling a little, little heartburn, and I'm going to have PPIs. So PPIs are not meant for long-term use at all. And PPIs can cause a lot of nutrient depletions like magnesium, bone loss. So definitely PPIs are not meant for long-term use, but it is very commonly used. Metformin is another one. And as you can see in that list, pregnancy, black ethnicity, and then all these dopamine agonists, glucocorticoids, Zoom, can't even pronounce that, MAB. So some of those are used in some autoimmune conditions. Some of them are used in cancer therapies. Then lithium, amiodarone, these are big ones. Endocrine disruptors are chemicals which come in your plastic containers like dioxins, then parabens, then bisphenol A, BPA. You must have come across products which are called BPA free. Well, the BPA free products are made from something called bisphenol sulfate, which is also not really safe. So it is technically BPA free, but that doesn't make it safe. So these are the things you need to remember. Lithium is again very commonly used in psychiatry. Amiodarone is another one. Then, of course, when you do the test. Now, every lab will insist that you go in the morning on empty stomach for the test. So that is not very difficult to control, but it is important to bear that in mind. So, what about the TSH levels that we look at in functional medicine? So, we usually like it to be between 2 to 2.5, and there are enough studies to support that in some conditions, maybe there is a specific TSH level where people do better. So, depression and PCOS, two of these are very common conditions. PCOS and Hashimoto's are very often together, and I am sure, just as in the rest of the world, you have a high incidence of PCOS. Worldwide, I think it has become now 1 in 10 women. That is really a very, very high incidence. And PCOS, as you know, it impacts women of all ages, right from adolescents right up to even menopausal women. And of course, the underlying problem in PCOS is insulin resistance. So no more about PCOS today, others will run out of time. So PCOS and depression, there are studies actually supporting this. So this is important to bear in mind, and I'm going to discuss one thyroid case so that it is more relevant to all of you, so that you can make certain changes in how you practice right away from tomorrow. So depression and PCOS, maybe you need a lower TSH level. Again, remember, age is also a major important factor. So this is the art and science of the practice. You have to make it individualized. So what is subclinical hypothyroidism? This is where serum TSH is high with normal total of free T4 and free T3 values. So this is the reason back some time ago I was talking about, if you test only TSH, you will not always know, because TSH may be high and you don't know about free T3, free T4. You cannot treat a patient based on only TSH. Neither can you follow up a patient if the patient is already diagnosed with Hashimoto's and hypothyroidism. You cannot treat a patient based on TSH only. Now, subclinical hypothyroidism represents mild thyroid failure, and it does have adverse clinical consequences. Now, in most patients, you do have to treat subclinical hypothyroidism, and I'll come to one more slide I have where who are the patients you're going to treat and who are the patients you can wait and watch. So obviously there is better symptom control, better cardiopulmonary function, better memory. All the things are much better when you actually treat a subclinical hypothyroidism. So this is a person with high TSH, normal, free or total T3 and T4. So who are the ones you're going to treat? Younger people planning, someone who's planning pregnancy definitely needs to be treated, because the guidelines recommend that TSH level for a woman before she gets pregnant should be 2.5. Then someone who has metabolic syndrome. Now, I am sure it is similar in all your countries. Metabolic syndrome is so common now. It's a problem of insulin resistance. Dyslipidemia is also a part of metabolic syndrome, insulin resistance syndrome. New onset of symptoms, depression, goiter, higher cardiovascular risk factors, and patients with positive thyroid antibody tests and a progressively rising TSH level. When will you start treating a patient with subclinical hypothyroidism? That is what I'm going to come to later on. So bottom line, yes, subclinical hypothyroidism is not something that we can ignore and tell the patient, oh, just go home and, we'll repeat your tests in 1 hour, 1 year and see what happens. No, they do need interference. Then, so what is the treatment that is traditionally recommended for hypothyroidism? All over the world, the first line of treatment is T4 monotherapy. So this is Synthroid or whatever is available in your country, you know what it is. So standard of care recommends T4 monotherapy to achieve normal TSH levels. However, there have been enough studies. In fact, a few years ago, the American Thyroid Association did a study where they asked people, this was an online questionnaire, they asked people how happy they were with the thyroid treatment. And a huge proportion of them said that they were not happy with their treatment, despite being in the, and I'm using air quotes, being in the normal lab range. And more importantly, many of them felt that they had to go to multiple practitioners because their regular doctor could not give them enough information. And that has been an experience with many of your patients. That is how a lot of them come to me, because I am not the primary caregiver for most of them. So after they start researching on the internet and they find that there are functional medicine doctors who can sometimes do a better job. But the fact is, bottom line is, not all functional medicine doctors may be trained well. So just doing a weekend course or something like that may not give you enough knowledge. But some of those patients have gone to 5 to 7 different doctors before they were satisfied with the treatment. So why is that happening? Now, we don't know everything, but at the same time, this has been, so the European Thyroid Association actually has guidelines in place. The American Thyroid Association does not have guidelines in place where they do recommend that if a patient is not feeling absolutely okay on T4 with lab ranges in what we would call a normal lab range, then there is a very good justification to try a treatment of combination T4 and T3. So a trial of therapy is very important. So before I go on to a trial of therapy, so one of the things that I want to mention is what happens with, so I work with a physician here who's also a functional medicine doctor. So many patients, when they come to her, they already come with the expectation that she is going to change their T4, which is what their family doctor was giving, to a combination of T3 and T4. So when a patient comes to you with the expectation that you're going to put them on a T3, sometimes, it is important to listen to them, but more importantly, you have to explain it to them and then give them the option. Because sometimes it may happen that one of the commonest reasons is if their T4 dosage was not adequate, if they had nutrient depletions. When I discuss the case, you'll understand that better. So once you have corrected and looked at everything else, maybe it is a medication that they are on, maybe they have, some other mood issues, maybe they're not sleeping well, maybe they have excessive stress. So once you have addressed all these other areas, maybe that is a point in time when you can suggest that we try adding a T3 and see how you do. However, if the patient says, no, doctor, I want to try a T3 right away, then this is where, functional medicine differs, in that we ask the patient what is it that, because, and many of our patients, and I'm sure the patients who are in the audience today, you've done a lot of research, so you do know enough about, something to understand when we explain something. But my point is, It is important that you should explain to the patient why you're going treating him or her in a certain way. So everything goes to what is the ratio of T4 and T3 that you should look at if you are planning on giving the patient a combination therapy. So physiologically, this is in the person who does not have hypothyroidism. The normal ratio of T4 and to T3 is, it ranges between 13 is to 1 to 20 is to 1. However, this is the interesting part. People who've been treated with T4 monotherapy, not on a combination therapy, with TSH in the normal range, and these are not people who are not feeling well. Many of them are feeling absolutely fine. Even they do not achieve a physiological T4 T3 ratio. So the bottom line is we don't know whether achieving the physiological ratio is everything, or that is even something we need to look at. Or should you feel like frustrated if you cannot achieve the physiological ratio? That is where you can look at the patient's symptoms as well as the labs and not focus on the labs only. The other major deciding factor is, and in India, actually in India, most of my patients are, all my patients actually, very few are ever on a T4, T3 combination. Because one thing is, I'm sure it's the same in Indonesia and Malaysia and Singapore, Vietnam, everywhere, where patients have to pay from their pocket for the treatment. Now, T4, the synthroid treatment, is fairly cheap all over the world, I think, as far as I understand. However, T3, some countries have a T3 available, like a cytomel, which is again depends on what is the dosage. It's 12.5, 25 micrograms, depends. Many countries don't have a T3 available as a regular pharmaceutical product. And the other important thing is the cost of T3 has gone up dramatically. So compared to T4 only, which is a very low cost treatment, a combination treatment, you do have to keep that in mind. This is where a compounding pharmacy would come helpful, because if you don't get that in your country, let us say, I'll come to the ratios and all that later, you need a specific amount of T3 which is not available as a pharmaceutical product, then the solution is obviously compounding. But compounding thyroid hormones is one of the most difficult things to do. That is why it is extremely important that you have a very good relationship with the compounding pharmacy, and your compounding pharmacy's quality control has to be extremely important. Otherwise, you will end up with a lot of problems, not the correct ratio, not enough, or too much of T3. That is not something you want. So it will depend on what is happening in your country. And I remember years ago when I first started off in functional medicine, I was like, oh, this patient, like, she needs to be on a T4, T3 combination. And I had given her one, and what ended up happening is, and she was somebody I knew outside of my medical practice, so she didn't show up for a long time. So one day I finally asked her, I said, what happened to you, you're not coming? She said, oh, you gave me a medicine that is so expensive that I decided not to go to you anymore. So that is why it's important to ask the patient what is it that she would prefer, and is the cost okay with her, because obviously she has to have it long term. It's not like having it for 1 month and then you forget all about it. The other thing is when you're giving them T3, T4 combination. Now, T4 has a long enough half-life. So once daily dosage is absolutely fine. But T3 has a shorter half-life, and it might need usually a twice daily, thrice is not common. So how do you avoid giving them a late night dosage of T3? Because if you give them a T3 late in the evening, some of them cannot sleep, some of them have more anxiety. So what has happened is, when we give a compounded preparation, very often it is one capsule which has a combination of T4 and T3, and many of our patients are absolutely fine with the once daily dosage. However, if you find that someone's blood levels of T3 are not going up as the way they should, only the T4 is going up and TSH is okay, and again, in the context of the symptoms and everything else that is going on, maybe you can consider giving T4 in the T4 and T3 combination in the morning, once dose, and a smaller another dose of T3 in the afternoon or evening. Evening, again, you have to warn the patient, if she feels she can't sleep and she's anxious, then that is not what's going to work. In some European countries, they also have a liquid preparation, and liquid preparation you can even compound. So there are many different ways of doing it. I think I'm not sure if some countries have a sustained release preparation as well. So there are different ways to look at it rather than only, treating with T4. So this is the recommendation from the European Thyroid Association guidelines. Start a combination therapy in T4 T3 dose ratio between 13 is to 1 and 20 is to 1 by weight. So they recommend that you give T4 once and daily T3 in 2 different doses. Now, this is one paper I would highly recommend you read it. It's an open access paper. And you can see from this, and a whole bunch of numbers are there, how to calculate. So first and foremost, you will decide, okay, the patient is getting adequate doses of T4. TSH, free T3, free T4 seem to be in the normal range or sort of in the range, if not optimal, but the patient is not feeling well and you have ruled out all the other causes, that long list I had shown earlier. Then you decide that, okay, I'm going to replace a part of the T4 with the T3. So important to bear in mind is, if you are giving a patient T3, you have to automatically reduce the T4, because T3 is made from T4. So if you are only giving them additional T3 without reducing T4, the total amount of T3 they get is going to be a whole lot more. So if you want to make sure that you can stick to the 13 is to 1 or 20 is to 1 dosage ratio, then this is a guideline to follow. And this is a really excellent paper to read. So he gives very practical, both the authors give very practical recommendations on how to do that. So desiccated thyroid extracts, I don't know if these are available in your country. Most of them are from a pig, so a pig's thyroid gland. And obviously for religious reasons, we cannot give that to a lot of patients, versus in countries like US and Canada, sometimes desiccated thyroid is available in the market, or sometimes naturopaths can give them. So a lot of people here do use desiccated thyroid, and a lot of patients say that they feel better on the desiccated thyroid versus being only on T4 monotherapy. And the other thing is, the desiccated thyroid, though all those challenges of quality control and whether the ratio is correct, whether there is enough T3 in it or not, those have sort of been regulated now because most of the desiccated preparations are standardized. But it is possible that because it's a foreign protein, it can trigger autoimmunity, though we don't have studies showing that. And like I said before, the ratio of T4 to T3 in the glandulars is 4 is to 1, which is not, again, physiological in humans. But however, sometimes patients may decide that they feel better on the thyroid extracts. So definitely you can try it out, and again, in conversation with your patient. So it's again the art and the science of the practice. The next thing is the thyroid set point. So this is, again, like I said, this is very interesting studies that came out of Singapore. So I've been in conversation with both the authors, and this is it's a mathematically derived algorithm. And if you go through that paper, you will realize that, very complex mathematics, but they have told me that they can explain it to me. They have explained it to me very well. The bottom line is, this particular algorithm needs to be validated in different ethnicities. So of course, Singapore is a very mixed place. So there are people of different ethnicities. However, I've been talking to them about, in people of Indian origin, it has not yet been validated. So however, it is important to remember that all your patients will not feel the same at a, in air quotes I'm using, a specific TSH level or specific T3, T4 level. Some people may feel better at a lower TSH, and obviously you may need to increase the dosage of their drugs, but also bear in mind that you cannot reduce the TSH levels to very, very low levels, because number one, it impacts the heart. Number two, it impacts bone. So super suppressed TSH is not the best way to go. And that is one of the ways where a lot of doctors can get into trouble, particularly with their cardiologist and their endocrinologist colleagues. I think I'm going to run out of time. I'm going to go ahead with the case. So just I'll leave it on for a little while for you to go through this. So how common is a patient like this? I'm sure all of you every day deal with someone with very similar complaints. So she is someone who is on Synthroid 50 microgram and she's taking multivitamins, but she has these challenges of losing weight, hypothyroidism, fatigue, high cholesterol, gastroesophageal reflux disease, anxiety. So look at all those things. And one of the things I want to stress upon is when we talk about difficulty losing weight, you'll be surprised to know that thyroid impacts a very small percentage of weight gain. Usually, the problem is insulin resistance, which is very common, not so much the thyroid. However, many people, when they switched from a T4 to a combination T3, T4, they felt that they lost a little bit more of weight. Now, sometimes we feel, patients will come and tell you, Doctor, I have hypothyroidism, that's why I cannot lose weight. That is not entirely true. However, optimal thyroid function is definitely important. Now, as I said before, when we look at thyroid function tests, what are the different tests we like to do? One, some are thyroid hormone related, then there are nutrients. Then we also look at drug induced nutrient depletion. So, something like, for example, metformin or PPIs, they deplete of, metformin will deplete a person of B vitamins. And if you have vegetarian patients in your, amongst your patients, I have a lot of people in India who are vegetarians. They usually have B12 deficiencies. So unless we correct the B vitamin deficiencies, it is difficult to treat everything else. Then we look at all these other areas. I'm going to rush a little bit because I'll run out of time. So this is a woman who is on Synthroid 50 microgram. Her TSH is 3.5. So hold that thought in mind. Is that normal? Then, of course, free T3, free T4, and as I've indicated on this slide, we would like it to be nearer to the the midpoint. That is where we look at it as when we talk about being at optimal levels. So again, her free T4 is not that high. The range is zero point 0.8 to 1.8, but she's at 0.87. And reverse T3 is not something we routinely test because in India it costs a lot of money. It's about $400, and because it's not done in the country. I don't know about your countries. I assume it would be similar. Even in Canada, patients have to pay for the reverse T3 test. Healthcare is covered here, so they don't have to pay for the other tests. Anti-TPO antibodies and was positive, so she's Hashimoto's, but anti-thyroglobulin antibody was negative, anti-TSH was negative. So bottom line, most of the time, I don't always test for an anti-TSH antibody, but I do test for anti-TPO and anti-thyroglobulin because some of your patients, though anti-TPO is the commonest one, some patients may be positive for anti-thyroglobulin, but negative for anti-TPO. So this is important to bear in mind, need to test both of them, maybe not all three, because if you have to keep the cost in mind, that is important. Lipid profile, now you remember she had total cholesterol. Fortunately, she was not on a statin medication. She had never had any heart problems. Her triglycerides are high because we like it to be around 120 milligram per deciliter. And again, her HDL is not bad, but her triglyceride by HDL-C ratio is high. So atherogenic dyslipidemia is the bad type of lipids. I won't have time to go into details in all of that. But you notice that because her triglycerides are high, her TG by HDL-C ratio is high. So if we want to bring down that ratio, we have to reduce her triglycerides. And triglyceride is related to insulin resistance. So that is important to bear in mind. Now, this is something very important because quite often there are a lot of patients who have iron deficiency. At least my patients in India, iron deficiency is extremely common. So if we look at only the hemoglobin, it is not enough. You can see from the hemoglobin 13.2 in a woman. Before I was in functional medicine, I would be quite happy to see that hemoglobin. But you can see that her serum iron is nearer the lower end. She has a lot of total iron binding capacity left. So there are a lot of sites which are still waiting for the iron to come in. Bottom line, a ferritin of 23. Ferritin represents the iron storage. The thing point of this slide is that she is deficient in iron. So giving her iron supplementation would be very important. And most of the time, I don't rely on only food, because this kind of deficiencies, food alone you cannot rely upon. You do have to give them supplemental iron, and I don't have time to go into the details, but all of you know how to supplement with iron. Important to bear in mind, see, some studies have shown, I have the reference at on the last slide, where when they push the ferritin to 100 by giving them iron, their thyroid seemed to work much better. What about the other nutrients? Selenium is another big one. You can see that this lady didn't have high selenium, but it was, sort of near the upper end. However, one thing to bear in mind is high selenium may be a marker of insulin resistance, but a few studies have shown that, giving selenium supplements, selenomethionine, 200 microgram a day, can reduce thyroid antibodies. So that is important to bear in mind. However, I haven't come across studies which show that if you give selenium to people who already have high selenium, whether the insulin resistance is going to get worse. We don't know. However, it's important to bear that in mind. Another thing is look at her zinc. Her zinc is also nearer the lower end, so we could give her more zinc. Vitamin D3 in this lab, the normal was 30, so she is definitely deficient. I've already talked about iron deficiency. Iodine, vitamins A, B, C, and E. I'm not showing the numbers here, but those are also extremely important. So, would you do an ultrasound of thyroid gland? Now, my medical practice in India is run through teleconsulting. So obviously, I cannot do a physical examination of the thyroid gland or of the neck. And given the COVID situation now, probably it may be necessary to do a thyroid ultrasound more often. Because see, the other problem is quite often you will do an ultrasound of the thyroid and you come across a nodule. What I do is I send it to my endocrinologist colleagues to do the FNAC to figure out whether there is any cancer. But there may be some situations where, is it that you're going to look for cancer when it is not really there? That possibility is there. So ultrasound, again, it depends on the person who's doing the ultrasound. So the radiologist's skill is very important. The instrument is very important. So what are the characteristics? You can see that list. So routinely, I do recommend the thyroid ultrasound if the patient has Hashimoto's, but that is because I cannot examine her neck. So I'm always afraid of missing something, missing a cancer or something like that, which is probably something that all of us are afraid of. We don't want to miss something that is major, right? So again, you need to decide whether, and the other thing is ultrasound doesn't have any radiation exposure. So it's a very safe test. So it's important to get this done. So this is the old slide. What are the different factors? I'm rushing a little bit because of the time. Now, what are the autoimmune conditions? So what happens with autoimmunity is if you have one autoimmune condition, your chances of having another one are higher. So what are the common ones that they have seen? This is the list. Again, see, one big thing is the autoimmune gastritis. So if they have a pernicious anemia, obviously that needs to be corrected and looked at as well. So the gut and thyroid are very intimately related. You can see the list, and there are more than 100 autoimmune conditions, but these are the common ones that have been shown in studies. So very important to bear in mind. The one that I see, vitiligo, or many of these, rheumatoid arthritis, these are conditions where the patient will have symptoms. However, diabetes antibodies is one of the ones that I usually like to test. But again, testing for diabetes antibodies is, again, those tests are not cheap. So you need to find out whether the patient is open to testing for it, because sometimes some patients may have what is called LADA, latent autoimmune diabetes of the Adam. So type 1 diabetes is not necessarily a diabetes of the young, and back in the days we used to call that juvenile diabetes. It's no longer juvenile anymore. So important to bear in mind. Next is what are the drugs. Now this is only one slide, and you will get a copy of the slide. So I'm not going to spend time in this. So you can see the whole long list of all the medications that can impact thyroid function. Some of them impact the function, some of them may impact the test results as well. So again, going back to the important questions I started off with, because I want to go to the patient now. So this 42-year-old lady, the same patient that I started talking about, what are the things you're going to give her? She's on 50 microgram of Synthroid. Her TSH is 3.5. She has anxiety. So is that a normal TSH for her? I would say no. So there are different ways of looking at it. Now, she describes her work stress as fairly high, 7 out of 10. But you see, sometimes when you talk about stress, it is important to understand whether that stress is bad stress or it's something that is a part of a job. So someone in middle management, and she's somebody who loves her job. So sometimes some of the stress, all stress is not always bad. So if it is the nature of her job which gives her stress and not because she doesn't like her job and those kind of things, so it's very different. So when we ask her, okay, your stress is high, she says, no, but I love it, because I love my job. I have no problems with that. So this is the stress conversation. All stress is not always bad. I want you to remember that. So what were the things she had? One is she had TSH was not optimal, given that she has anxiety. Her cholesterol was high. So definitely we need to do something about that. Then her fatigue could have been from iron deficiency. Remember, she had iron deficiency, she had vitamin D deficiency, and a whole bunch of micronutrients, which we can't always check for all the micronutrients. So that could have been from the fatigue. It could have also been a part of the thyroid because hypothyroidism, one of the symptoms is fatigue. GERD, again, it is possible that she was, eating more carbohydrates than she could tolerate. You remember her triglycerides were high and she has difficulty losing weight. So number one is, what would you do? Would you increase her 50 microgram of, T4 right away? Or would you rather correct her nutrient depletions, check all the other things, and then look at increasing her thyroid medication? So this is how I would manage it. But again, each person is different. First of all, of course, I would start with her gut. Her gut has to be healthy first. The other thing is, sometimes we forget, we assume that patients are taking their medications the way they were supposed to. So is she taking her medications regularly? Is she having her Synthroid daily? And if she's having her Synthroid, is she having it 1 hour away from food or drink? Or is she having her Synthroid along with a bunch of other supplements all together? Then obviously it could be a question of absorption, particularly if she's having it with calcium and iron and everything. So for me, important thing is to correct the nutrient depletions first. Why would I give her selenium? One, okay, I'm just backtracking a little bit. One absolutely, absolutely important thing to do would be to get her off of gluten if she is taking gluten. Stopping gluten has shown in many patients, every day we see that, many studies, that thyroid antibody levels go down. So that is non-negotiable. Iron, D3, of course, selenium, zinc. Why would I put her on an omega 3? One is for the high triglycerides, and an omega 3 is very good for brain function as well. She has anxiety. Omega 3 has so many different functions, and it is an essential fatty acid, which means your body doesn't make it. Then I'd also put her on 200 microgram of selenium. Now, when are you going to repeat her thyroid function tests? So here in Alberta, patients can get their tests done from the government lab. They don't have to pay for it. So here we usually repeat in 6 to 8 weeks. However, you can also stretch it to 12 weeks because at 12 weeks, patient can go just once to the lab and get tested for iron, for D. But usually we do not repeat most of the other labs other than the thyroid, TSH, free T3, free T4. We do not repeat them at lesser interval than 12 weeks because most of the time you'll not see a whole lot of difference. And more importantly, we do not test the thyroid antibodies very often. Usually it can take anything between 6 to 9 months to a year for thyroid antibodies to reduce. So some of my patients in India, because in India they can just tick the test chart and they decide, okay, I'm going to repeat my thyroid antibodies. I said, why did you repeat it in 3 months? This is not going to reduce. No, doctor, it has not reduced as much as I thought it would. I said, no, it's not meant to. That's the reason I don't repeat it so often. So thyroid antibodies, you don't need to repeat 6 to 8 weekly. You can do that every 6 months or a year because it's not going to dramatically change in a short span of time. But remember how this patient's basic problem, one of the things she said is she has a problem with weight loss. Now, only managing thyroid here will not reduce her weight. So you have to address, very likely she has insulin resistance. So insulin resistance is a different, another webinar probably. So you need to address insulin resistance. How we look at it is a lower carbohydrate diet, time restricted eating. Then when will you test for heavy metal toxicities? That is something we leave for the last, because you cannot do a chelation on a patient who hasn't been built up already. And I am not an expert in chelation. We usually send the patient to our naturopath who's trained in it. So heavy metal toxicities are not to be tested right at the beginning, though they do have an impact, but you cannot do a chelation, right away. So I think that brings it to an end. I have just managed it in 1 hour, so I'm just 15 minutes behind, Sarah. Sorry. So in case you want to get in touch with me, this is my weekly email. Go on to my website, drkarmd.com/email, and you can subscribe to it. And I usually send what I think is valuable information. You always
It
have the
is.
option to
It is.
unsubscribe. Okay, thank you very much. This is the reference, and I'll stop sharing my slide, and we are open to questions.
Yep. Any questions, anyone? Or
You
everyone's
can just
overwhelmed?
type in the chat box, or you can ask also. You unmute yourself and ask. Either way is fine.
Yep.
Oh, thank you so much. Thank you, Simran. And any more questions? Oh, I can see someone's from Chennai.
Is it?
Yes.
So I got some new patient referred to me just today. It's
Mm-hmm.
he's 72 years old, and I haven't had any lab tests yet, but the only complaint was at the beginning of this year, this man, the children said that this man just suddenly looked very pale and went to ER and apparently got very low natrium, so just low blood sodium.
Mm-hmm.
So then since then he got hospitalized 4 times just for IV natrium basically.
Mm-hmm.
But I asked if they considered the thyroid, considered the adrenal. That's the only two that has not been tested. So I was thinking to test that. And he also has anemia, so his hemoglobin is only 10.
Okay.
So
Okay,
what do you think?
we have a few questions. Anyway, yes, so definitely looking at thyroid in an older population. And recently, two of my relatives were talking about. So these were older people. They hadn't been looking at their thyroid for a long time. Some of them forget their thyroid medication, so they stopped the medication. And then they found out one had a TSH of 36. So
Wow.
and another person had heart problems because of the thyroid. Now the sad thing is
Yeah.
thyroid is easily correctable. So yes,
Yeah.
it is extremely important to look at the thyroid. I'm just going to the questions. One question is how to combine Lugol solution and T4 T3 hormone, dosage of each. So usually I never recommend iodine supplementation unless we have tested for iodine deficiency,
Yeah.
because with iodine what happens is if you give them excessive iodine and they are not deficient in it, it can push them into thyroiditis. So iodine is never to be given blank, at random without testing. That is what we do. I know some people give iodine, but it's again depends from person to person. Another question is at what fibrosis stage the thyroid hormone therapy cannot reverse heart and or kidney fibrosis, and what do the labs look like? So again, I am not sure I understand the question completely. So this is fibrosis of the heart and kidney from what condition? Like I talked about this elderly gentleman, he had hypothyroidism for a long time. It was not detected. Like Sarah, you said they didn't test for the thyroid yet in a 72-year-old man. So it is difficult to predict. Uh, it is difficult to predict whether the how much of the thyroid tissue is remaining if it is hypothyroidism you're looking at. And some point you are right, it may become irreversible if the patient has had undetected hypothyroidism, untreated hypothyroidism, Or like this gentleman, my relative, who forgot to take his tablets. He just thought that, oh, that's not something I need anymore. So therefore, it is very important to continuously monitor. So, and I don't really know whether there is a specific way to find out at which point it becomes irreversible completely, but yes, long term, definitely. Another question is there any correlation between TFT and long term hypertension treatment? Very good question. So the thing is, uh, again, depends on many factors, because hypertension is not only hypothyroidism, but yes, managing the thyroid along with everything else. So if the patient has hypertension, it's important that the patient remains on thyroid medications, of course, and antihypertensive therapy as well. But over a period of time, because you're going to observe the patient and monitor continuously, so definitely sometimes it can happen that blood pressure goes down. The other thing is, two of the big things which will reduce blood pressure are not even related to thyroid. One is weight loss, and the other one is deep sleep. If they're not getting good sleep, that can have an impact. But I wouldn't suggest that you can rely on only thyroid medications to reduce blood pressure. It has an impact, but not enough. Depends on how much the blood pressure is. Okay, another one is wanted to dig in more based on what you have explained. Somebody shows symptoms of thyroid problem besides TSH, free T3, free T4, and antibody. Is it very necessary to check on the nutrient status? Yes, considering the lab test for nutrient status is not cheap in Indonesia. So nutrient status, things like iron, selenium, zinc, B12, vitamin D, that would come as probably, that is a very common set of tests in most countries all over the world. Here, I'm not talking about testing for micronutrients, which is again a functional medicine specialized test that costs a lot of money. We don't always do that, even in Canada, because it costs about $500 to $600, which is not a small amount of money. So if you have, your patients telling you that I don't want to do so many tests because it is expensive, you also have to explain to them that if you don't test for iron deficiency or B12 or D3, those are fairly easy to correct. Then obviously they cannot get the kind of results that they're expecting. Like they come to you and they feel that they should be fine next, in 2 weeks. It may not happen if they have multiple nutrient deficiencies, which you have not been able to find out because they don't want to test. So manage their expectations accordingly. So this is the optimal. I get this quite a lot. Doctor, do I have to do all the tests? I said, yes, if you want all the results, you would have to do. Maybe you can do it in stages, budget for it. Do some this month, maybe next month when you get your salary again, you can do. So over a period of 2 to 3 months, you can do that. But at the same time, remember that you may not feel you're absolutely fine in just 1 month if you haven't done all the tests. How about patient with low TSH, low end FT3 and normal free T4 level? Do you consider to treat this patient as central hypothyroidism? Central hypothyroidism is not as common. So in a patient like that, I would definitely look at all these other factors, the nutrients, the medications, the endocrine disrupting chemicals, the whole lot of stuff before, looking at, again, if a repeat test shows that the TSH is still high and the free T3 and low end free T3, then you might consider giving them treatment. I would definitely consider giving them treatment, but after correcting the nutrient depletions and everything. An important factor, if you remember one of the slides I have, if they have thyroid antibody levels are high, then subclinical, this is not really subclinical, it is low end free T4, free T3. So low TSH, meaning this is going more towards a hyperthyroidism, if you mean, then definitely uh, no, that is again a different story. Sorry, I got the question wrong. Central hypothyroidism is again something that, after ruling out everything, see what happens when first time you come across labs which are not really making sense. Most of the time we repeat them. And sometimes I know in India we change the lab because we have the option. We ask them to go to a different lab and test the same things. If you feel that it's not making sense at all and you have looked at everything else, sometimes on repeat testing, the reports come back quite different. I usually, if I'm suspecting central hypothyroidism, which is not common, I would send them to my endocrinologist colleagues because that is not my area. In subclinical hypothyroidism, is it worth combining T3, T4, DHEA, hydrocortisone dosage of each? Okay. So number one, I do not give hydrocortisone as the first line ever. That is to be one of the last things you can think of. Yes, it is worth combining T4, T3, but like I said, I've explained all this in the entire presentation on when I would decide on a combination. And yes, all the other hormones like your estrogen, testosterone, progesterone, hormone balance, all the hormones are relevant for thyroid. But would I start with everything together? Probably not. Because then what happens is you won't know which one is showing the biggest impact on them and which is the one that's not doing anything much. So that is important to bear in mind. And again, the same thing about the ratio and all of that. Dosage of each will depend on what the levels are at. But subclinical hypothyroidism, most of the time, I start with nutrient depletion, correcting nutrient depletions first, because you'll notice many of your patients will say, doctor, I want to go the natural way. Can I do without medications? In such a patient, correcting nutrient depletions first would be very important. Another question is, I'm confused about physiological ratio of T4, T3. Is it for combination therapy ratio? Or can we use the ratio to assess thyroid function? So usually we do not look at that, at the ratio, physiological ratio of T4, T3 of 13:1 to 20:1 for physiology, because uh, if a patient has hypothyroidism, that ratio may be abnormal. Now, the thing is, that is more, and not thyroid function assessment, I wouldn't go with the ratio as much. Like I said, if you keep focusing on ratios, you end up becoming a micromanager of thyroid. So just go back and read those references to the slides, on the slides which are there, which will probably give you more clarity. So though we like to aim for the physiological ratio, the important thing to bear in mind is many patients on T4 who have not achieved that physiological ratio feel fine, and we don't know why. So that is why you have to treat, test, and repeat. What are treatment plans for asymptomatic patients with positive thyroid antibody to prevent? Oh, fantastic question. So yes, number one, get them off of gluten. And when I say get them off of gluten, it means 110% off of gluten. And that doesn't mean they start eating gluten-free food, which is a lot of sugar and a lot of processed food. That is very important. And so that is one. Then you can put them on selenium if their selenium levels are normal. So usually a lot of my patients in India, they have high selenium and all of them have insulin resistance. So I normally wouldn't put them on selenium if they have high selenium levels in blood, but I would insist that they get off of gluten. That is one. And the next is, of course, you need to repeat the test, because sometimes what happens is, the TSH levels may be trending up. And studies have shown that thyroid antibodies can show up in blood 7 to 8 years before they actually become symptomatic. And the other thing is, see, thyroid symptoms are so non-specific. Have you ever come across any patient who comes to you who doesn't have anxiety, who doesn't have fatigue, who doesn't have aches and pains, who doesn't have, complaints of hair fall? Like, thyroid symptoms are so non-specific. And do you realize that they all overlap with menopausal symptoms? So where would you draw the line to say that they are not symptomatic? This is the question I always ask people when they talk about, hormone therapy for women. I said, show me one woman who comes to you who doesn't have any of these symptoms. And you can say the patient doesn't have menopausal symptoms, so I'm not going to put them on hormones. So that is, how can thyroid become resistant, doctor? The pathophysiology. Oh my goodness, that is outside my expertise. So that is, thyroid resistance is it's a genetic problem and more in the world of the endocrinologist, not my specialty. So it's very important to know where my area lies and where my area doesn't lie. So things like, Cushing syndrome or any of those, I'm not an endocrinologist, I wouldn't treat. Similarly with thyroid, and thyroid resistance is not a common thing. Again, like we talked about before, there's so many modalities of treating it. Maybe this is what you are thinking as thyroid resistance could be someone who needs a combination treatment. So it will depend on that. Is it okay to give T3 without T4? Chronic fatigue patients are advised to take no. Yes, it is a problem. So usually we never recommend T3 only unless it is a patient in whom you have found that the reverse T3 is high. So if you remember from the physiology, from the chart I showed where T4 gets converted to T3 and reverse T3, and if your patient has been tested for reverse T3 and reverse T3 has been found to be high, in such a patient, you can give only T3, but again, you have to test and repeat. So, like I said, we don't often test for reverse T3, usually not at the first this thing, but some patients come with all the knowledge about, they have been reading up about reverse T3. So we do test them. So chronic fatigue patients, based on if the lab is not showing a deficiency in thyroid hormones, not showing hypothyroidism, not showing Hashimoto's, thyroid hormones are never to be given. So there is no role of thyroid hormone therapy in someone who does not have hypothyroidism. For some people back in the, I think, 1920s or so, they used to give them thyroid for weight loss. That is not good medicine. So without any hypothyroidism, no thyroid hormones to be given. Yes, if it is very suppressed, it can be a problem. Okay, all of you had excellent questions. So I think that's it. Okay. Thank you very much.
Thank you, doctor.
You're welcome.
Thank you, doctor. Thank you so much. We learned a lot from you. Thank you so much.
Thank you. Thank you so much. All of you had such excellent questions, and thank you so much for investing your time here. What is the optimal TSH for PCOS? It is the last question. It's there on the slide. It is 2 to 2.5.
Can we have a slide, please? Can we have a slide?
Yes, yes. I did say I'm going to send the slides.
Sure. Okay.
Okay. Bye now.
Thank you.
You're welcome.
Dok Sarah?
Dokter Sarah speakernya belum dibuka.
Yuhu.
Nah udah keluar.
Sarah, kita bisa close kah?
Yeah.
Can we close now? Yes? Okay. Yes. Because I think the participant is a little bit confused.
Yep. Okay.
Okay.
Yeah. Bye. Have a good weekend, everyone.
Thank you to all participants. I think we already done for today. We'll see you at our next webinar series. Thank you so much. Bye-bye.
Bye.
Dok Lisa.